Okay. My name is Emil Goganeni. I'm an attending physician here at Ohio State University. I treat head and neck cancers in the radiation oncology department. I have been the host of these webinars for a couple of years now at ACR. It's been great. We've had some fantastic different topics and speakers. And I will be transitioning this role to Dr. Upadhyay, who will be taking over from here. And he will be basically hosting this and the webinars going forward. So we're happy to have him join our team at the ACR, and then I'll hand it over to him from here.
Hi, good morning, everyone. Welcome to this webinar, and thanks, Dr. Gogineni, for the kind introduction. So, yeah, I mean, we've been doing this for several years now, and it's been a very successful series, and this will be the first webinar of the 2025 year. We have a good team of speakers here and really looking forward, even myself, I'm looking forward to listening to this. So the topic today is going to be distinguishing immune-related versus radiation pneumonitis following thoracic radiation therapy. Our host today is me. I'm a resident at Ohio State University, and Dr. Gogineni, who is attending physician, as you just heard, at Ohio State University, and Dr. Amini, who is at City of Hope. And our speakers today are going to be Dr. Drew Moganaki from University of California, Los Angeles, and Dr. Sharon Katz from University of Pennsylvania. Could we move on to the next slide, please? Oh, the next one, I guess. So it's a sequence of speakers, and we'll go through it in more detail in a minute. But I wanted to just start quickly with the learning objectives of this webinar. Next slide. So we're going to start by looking at interpreting findings seen on post-treatment CT and PET imaging after radiation therapy for thoracic malignancies. We want to identify pathophysiology, clinical features, and diagnostic strategies to differentiate between radiation-related and immune-related pneumonitis. And finally, we want to describe the management of radiation and immune-related pneumonitis. A little bit about our accreditation information, if we can move on to the next slide. So this is our webinars are accredited by the Accreditation Council for Continuing Medical Education. So for looking at physician's credits, each activity is designed for a maximum of 4 Category 1 credits, and physicians should claim only the credit commensurate with the extent of their participation in this activity. Next slide. So how to obtain the CME credit? You have to complete the activity and activity evaluation to claim the credit, and the deadline to claim CME credit is May 19th, 2025. You can email at info@acr.org for more information. And then lastly, moving on to the disclosures. Next slide. Our disclosures, speakers have ensured the content of this activity was vetted and to assure objectivity and that the activity is free of any commercial bias. And next slide shows the disclosures of all the speakers in detail. With this, I would like to move on to our first speaker for the day, Dr. Drew Moganaki. Next slide. I'm sorry. Okay, I'll just give a brief introduction. Dr. Moganaki is a professor and the chief of thoracic oncology at the UCLA Health's Department of Radiation Oncology, where he leads an endowed thoracic oncology research program. He's also the co-director of VA Greater Los Angeles Lung Precision Oncology Program, where he leads the multi-site phase 3 VALOR study. Everyone is excited to hear results of this study, which is comparing SBRT with surgery for operable stage 1 lung cancers. I had a lot of things to say, great things about Dr. Moganaki, but I'm going to cut short on that and hand it over to him to move on to our topic, the first talk of the day, which is to discuss misunderstood post-radiotherapy scars.
Raj, thank you to you, and thanks to Emil and the ACR team for making this possible. My research team has actually taken a particular interest in this issue of misunderstood scars. So my job is to set the stage for Dr. Katz to help us understand what to do about these scars. So I think, and I would assume, that everyone on this call is aware of the radiographic uncertainties that emerge after thoracic radiation therapy. We see these common after SBRT and common after chemoradiation, whether concurrent or sequential. These scars are fortunately often asymptomatic, and it's curious what they actually are. Is it inflammation, such as an itis, or is it just a healing wound, which I guess could be an itis as the immune system is scarring down the area that's slowly denuding and atrophying from ionizing X-rays. Unfortunately, there's impact on patient care because misinterpretations are inevitable, and here are the consequences. In a patient with a highly curable stage 1 lung cancer treated with SBRT, they could have unnecessary PET scans, unnecessary biopsies, and even unnecessary surgery, although the latter has been happening less and less before, as it was only in the early days when we were doing salvage lobectomies, for example, on people who had no residual cancer. And more so than ever before, we're seeing misinterpretations after concurrent chemoradiation to be followed by, for example, durvalumab, with completely asymptomatic patients with just to be expected radiation changes being started on high-dose steroids, 60 to 80 milligrams even, and then unfortunately discontinuing the IO. And so that's why we decided to make this the focus of this presentation, this webinar, which is the latter about after chemoradiation and IO. However, just real quick, as we're trying to figure out how to even communicate the expected changes, I want to make sure that everyone participating in this webinar is familiar with what I would call a landmark publication. It's a pictorial essay that at least gives some words to these scars that radiation oncologists have generally historically been unfamiliar with. So here's just some vocabulary to consider. It's not to make life more complicated, but in fact, it's to harmonize our vocabulary with that of our radiology and pulmonology colleagues who are actually very familiar with these terms. Here you can see patchy ground glass opacities, something called a modified conventional pattern of fibrosis, or some sort of a scar-like fibrosis, again, in patients without any evidence of disease otherwise after SBRT. You can see these, you can see these, and you can see these. And one thing that I've learned is that when you do see these bronchograms kind of not being kinked or moved around, that leads us to think that the density that we're seeing is not a mass-occupying tumor, but instead just evolving scar. You can see the architecture of the bronchograms here look pretty normal. So let's talk about another challenge, which is assessing the response to radiation therapy, whether SBRT or chemo-RT. So it's a gold standard for radiographic assessments in drug trials, but it was not developed for radiation therapy. And here is an example of what can happen when we use the progression by RECIST criteria. So RECIST says that you have progression if you have an increase in 20% of diameter and at least a 5 millimeter increase in diameter compared to the minimum diameter. So look here, you've got a 20 millimeter tumor treated with radiation therapy. The minimum is now 10, and it grows by 5 millimeters, which is 50%. If you were to be reviewing the results of a clinical trial, the case report form would require the coder to call this progressive disease. But is it progressive disease? The original tumor was 20, and what happened from 10 to 15 could be nothing but benign scar. In another important paper that was published just last year, a group looked at the predictive value of RECIST following lung radiation. They looked at a cohort of 88 targets, all treated with SBRT, and using the definitions from the previous slide, 2/3 of them met the RECIST criteria, but only 9 of them had confirmed progression. This gives you a PPV of 0.16, which is why it's nice to at least have it as a reference, but it is an unreliable metric for evaluating response to treatment. So as mentioned, for the rest of the talk, we're going to transition over to the erroneous attributions of pneumonitis for locally advanced lung cancer. I would assume again that everyone in this webinar attending is aware that the standard of care for stage 3 lung cancer is basically a 14-month journey of chemoradiation followed by a year of durvalumab. We have excellent long-term outcomes, and you can see here an independent review. The progression-free survival is 1 in 3, never needing any more treatment after starting durvalumab. But the problem is that what's happening in real life might not be the same as what was reported in the study. So overall, the effects of chemo-RT on the lung leads to symptomatic grade 3 pneumonitis in only 2 to 3% in the most contemporary large phase 3 studies looking at chemo-RT for intact stage 3 lung cancer. And we see that durva can be discontinued, especially as it was in the Pacific study, due to either immune-related AE or radiation pneumonitis. And not surprisingly, the factors that lead to a higher risk of TRAE, so we don't know if it's radiation or the drug, is about 3.7 in patients with interstitial lung disease, and still higher, of course, we know, if the radiation treatment plan is larger, leading to a higher mean lung dose. But in real world practice, we're seeing evidence that durvalumab is discontinued in about 1 out of 3 patients. And as I showed in the previous 5-year update slide, we're talking about a 10-year overall survival benefit that could be deprived if that attribution is made erroneously. Here is a case study of mine at a leading high-resource medical center, where the patient pre-treatment, you can see the tumor on the left, treated with concurrent chemo-RT, and because of these wisps of GGO changes, the radiology report said pneumonitis. The medical oncologist started the patient on high-dose steroids. The patient never had any symptoms. In fact, when I talked to them soon after this, 1 week into the high-dose steroids, they told me they actually felt better when this at 4 months than before treatment when they were symptomatic. And you can see here, even with the steroid, it doesn't necessarily change the course of treatment in this patient who otherwise now had symptoms from the prednisone. And as mentioned, the durvalumab had been stopped. So here's just a sagittal projection of the same situation. And to a radiation oncologist's eye, that picture in the middle there, for us, this is clear for us. These are beam tracks coming in through the spiraling discs of what we call VMAT radiation therapy. And there does not seem to be any sort of pulmonary changes outside of the expected radiation field. But the astute radiation oncologist is aware that our colleagues outside of our discipline don't necessarily have access to the images to know where the radiation treatment was delivered. And you can see here that the evolution is going on. You know, basically those GGO areas are consolidating and getting into consolidation. This is not an area of progression along the chest wall, which is distant from the primary source of the mass, which appears to be continuously shrinking. So in one of the last few slides that I have, just to set the stage here, this is also, I think, a very informative study out of the Netherlands, where they looked at this problem in a little more detail to try to find some proposed solutions. So in a cohort of 45 patients treated with Pacific regimen, 1/3 were diagnosed in the record with having pneumonitis. 1/4 of them were stopped, had their durvalumab stopped, and almost all of them were started on the high-dose steroids, as was the case with my patient. And the immune-related AE pneumonitis after retrospective review, when a thoracic radiologist looked at it and had access to the treatment plan, you can see significantly drops the assignment of the immunotherapy causing the pneumonitis, and instead of attributing it to the radiation therapy with or without symptoms. And interestingly enough, I thought was the main take-home point of this paper, because we know our radiologists can figure this out. The pulmonologists appear to be just as good as a thoracic radiologist, kind of piecing things together if they have access to the treatment plan. But look at what happened actually. If they didn't have the plan, they kind of figured out, okay, this is probably where the beams went. And when they had the plan, they had an even lower rate of attribution to the immunotherapy, and instead were more comfortable assigning it to the actual radiation therapy, again, with or without symptoms. So I have a proposal in this webinar and in future talks, is that it would be really nice, I think, for our medical oncology and pulmonary colleagues, if the radiology report just had these 4 special words at the end. We're all familiar with correlate, clinically, but correlate with radiation therapy fields, would, of course, it does, of course, create a task to get access to those fields. But as we can see here with the difference in the numbers on the left and on the right with access to the treatment plan, there are meaningful clinical impacts that can be attributed, especially making sure we don't erroneously stop potentially life-prolonging or life-saving immunotherapy. So my take-home messages are the following. We know CT changes are common, and unfortunately, they can be misinterpreted as either progression or pneumonitis. We have to always remember a differential diagnosis. It could be just benign scarring. However, it could also be infection. We have to think about local recurrence all the time. And we have to be aware this actually could be masquerading as lymphangitic carcinomatosis. So close surveillance is crucial. And then number 3, just want to hammer one more time, inappropriate immunotherapy interruption could lead to a clinical tragedy, therefore elevating the importance of this topic. Number 4, we need to educate our colleagues outside of radiation oncology about the utility of plan review, and more importantly, make them readily available. And radiology reports hopefully can evolve and include these 4 magic words. That's the end of my presentation. Thanks.
Thanks a lot, Dr. Moganaki. That was incredibly insightful, and I think that's a question we deal with it on a daily basis. Well, there is some pneumonitis. Is it radiation or is it immune related? So with those thoughts in mind, I would encourage everyone who has questions to put them in the QA section or the chat, and we will come to all the questions towards the end. But with that, I would like to move to our next speaker, Dr. Katz, who is an associate professor of radiology and the director of Tumor Response Assessment Core, as well as Oncologic Imaging Service at the University of Pennsylvania. Her research is focused on thoracic oncology imaging for detection, staging, response evaluation, and treatment guidance for thoracic cancers, with a special focus on lung cancer and malignant pleural mesothelioma. With that, I would like to hand over the stage to her. She would talk to us in more detail about the radiology behind this and how to distinguish different kinds of pneumonitis on imaging. Dr. Katz.
It's a pleasure to be here. Thank you for having me. I'm just going to share my slide deck. Okay. So it's a pleasure to be here, and thank you for your attention today. And I agree with Drew's, all the points that Drew made in his talk that preceded mine. It'd actually be incredibly helpful if you provide your radiologist with the treatment plans. That's actually something we're working at in our institution, is making that available in the clinical record for every patient, so that we can see it. It makes us a lot smarter as radiologists if we know where they've been irradiated and when. And we'll talk a little bit about the expected patterns that we see after radiation, and also in the setting of immunotherapy. Just first, I have no financial disclosures for the materials that are being presented here. We'll start with a brief review of the evolution of radiation-induced changes in the lung, and this will echo some of the points that Drew mentioned earlier, and then we'll talk about differentiation between expected changes and local recurrence, and then also considerations for patients who are on immunotherapy, and talking specifically about the differential diagnoses that should be considered with the various patterns. So early radiation changes in the lung can mimic disease progression, as was mentioned. You can get peritumoral consolidation, interlobular septal thickening. That's par for the course. And in order to really differentiate these changes with tumor recurrence or other superimposed infectious pneumonia, it's very helpful to know, as I said, where patients were irradiated and when. And to consider the timing of the changes, where they are in that spectrum of evolution of radiation-induced lung injury following therapeutic radiation. And so in the first 2 months, as you may know, you actually initially see nothing. And then within the first, towards the end of that window of first 2 months, you start to see some patchy ground glass, typically very quickly escalating to consolidation. And that peaks around 2 to 6 months, where you have a organizing pneumonia pattern that's admixed with ground glass, and there's architectural distortion. And then in that window, towards the end of that 2 to 6 month window, you start to have evolution to a more band-like mature fibrosis that continues to kind of retract into typically more of a band-like morphology, although sometimes retracts into a more mass-like morphology, and that can be tricky to interpret if you don't have the whole spectrum of change, if you just have a single time point. And then around 6 to 12 months, usually it's kind of matured into its final form with a band of fibrosis, characteristically with traction bronchiectasis, dilated airways running through that fibrotic lung. And usually those changes have stabilized by 2 years, if not sooner. So this is we'll go straight to having some examples to kind of talk about this kind of progression of changes on CT. So this is a non-small cell lung cancer. At baseline on the left, we have a small nodule on the right lung on the background of central lobular emphysema. At 3 months of radiation, this patient is actually not showing much in any way of change around in the lesion in the surrounding lung. But you do see a decrease in the caliber of the tumor. And that's actually one of the first things you see, is that the tumor starts to decrease in size, sometimes even before the surrounding changes manifest. By 8 months, you can see some patchy ground glass, consolidation, architectural distortion, and some kind of bands of fibrosis. If I just saw this last time point without any other information, and I didn't know they had lung cancer, and you're just presenting it blind, I might I would have to consider infection. Knowing that there was a treated lesion there, then, and knowing that they've been irradiated helps me to come to the right diagnosis that this is post-treatment changes. So it's really important to provide your radiologist with that information, letting us know where patients are in the spectrum, in the course of the disease management, and when they've had significant interventions like radiation. Here's another example. So this is non-small cell lung cancer, treated with SBRT. There's 2 nodules. There's a primary and a metastatic nodule that were treated. And so you can see in this case, there's focal consolidation. This is 2 months after SBRT. If you had, weren't careful, you might consider that the lesion, the lesion there's more consolidation at the site of the treated lesion. You have to be careful not to interpret that as worsening of disease. Things that can help you discern that, this is radiation-induced injury, besides the fact that you're knowing that you're only 2 months out. Knowing if you actually take these cases and look at an orthogonal plane, so coronal sagittal plane, radiation-induced lung injury typically will, this consolidation that you're getting at that site of the treated tumor is typically flat, more like pancake-like. If you have more increasing 3D volumetric disease, that's more concerning for local progression. But you have to be incredibly careful about calling that so early out, given that you're in the peak of that in post-radiation inflammatory consolidation. Here is another case. This is a mass in the right lung, non-small cell lung cancer treated with IMRT. 4 months out, you've got robust patchy consolidation in the treatment zone. You can see a little bit of the residual tumor here. would not measure that. And you have no idea how much of that is viable. Same for the following. I mean, you can see due to the displacement of airways, the mass effect from the lesion that was treated, I would not measure that because I have no idea how much of that is treated and how much of that is just, residual, sterile tumor. So, or tumor tissue that, from at the site of the treated lesion. So in these cases, I mean, I as a radiologist, I don't measure. Instead, I look for evidence of progression. So I'm looking within that zone of radiation fibrosis for what looks like increasing consolidation, displacement of airways, and with contrast, and I strongly recommend using contrast in these cases, you can see a differential enhancement between the tumor and fibrotic tissue. The fibrotic tissue, especially once it's mature, tends to be more uniformly enhancing. And you'll see this kind of area of low attenuation within that fibrotic enhancing tissue when you have locally recurrent disease or residual tumor. So, as I mentioned, features associated with local recurrence include increase in that mass-like consolidation, although you can see that in a single plane, even with the retraction of radiation-induced lung injury. So it's not always, seeing increased mass-like consolidation on your axial image does not necessarily mean that you have local progression, but it certainly should make you think twice and further characterize those findings. Again, sometimes looking at the orthogonal plane will help you. If it looks like it's increasing consolidation, you turn it onto the coronal and it looks quite flat, it's probably radiation fibrosis. So having said that, I would still follow it carefully. Loss of bronchiectasis within that fibrosis, having nice previously dilated airways that look like the far right picture that disappear, or you start to see mass effect or cutting off as a displacement of those airways should concern you for local recurrence. Development of a pleural effusion late, very common early within the first 6 months, even up to a year. Beyond a year, if you get a new pleural effusion, I mean, certainly there are other comorbidities that can cause that, but it should be a red flag that you may be dealing with a recurrent disease. And then increased FDG avidity. You can have, inflammatory changes in the early months following radiation, and that's, not a good time to be assessing the metabolic activity of your tumor. Having said that, usually even in that early window, that FDG avidity is dropping. If you see a rising FDG avidity within the tumors, particularly after 3 months, that's a red flag that you may be dealing with locally progressive disease. So here's some examples. Here's an example of local control. So we've got a lung cancer on the far right perihilar mass, intensity FGG avid, 4 months after radiation of proton therapy. You still see some soft tissue, but it's completely non-avid on PET. So this is kind of that residual kind of treated soft tissue at the site of the lesion. Really large masses tend to leave kind of more soft tissue in the treatment zone, which can be confounding at times. This is 6 months and 13 months out. This person actually had kind of a late, a little bit later blossoming of that radiation-induced lung injury into consolidation, that organizing pneumonia that you see following radiation. Also developed a small effusion. Again, that's pretty common in that early stage of radiation-induced lung injury. By 13 months, you can see that this has evolved into a band of fibrosis. You can see nice airways going through it. And if you look at the PET, it's completely, it's at background. So no, it's at the same avidity as the mediastinal blood pool. This is successful local control. Let me give you progression. So this is a mass in the left perihilar lung at baseline, intensely avid. At baseline, at 4 months, you're starting to see some patchy consolidation. This is again proton therapy, some patchy consolidation in the treatment zone. Mass itself has decreased in size. But now, and then you can see at 10 months, you have a nice band of radiation fibrosis, and there's some traction bronchiectasis within it. But even at this early point, well, that's looking pretty good, and you wouldn't at that point be too concerned. You'd be thinking this is expected changes. You still see some avidity at the site of the treated lesion, more than I'd like to see at 10 months following therapy. Really should be pretty bland at that point. And sure enough, on the follow-up at 25 months, there is now filling in of those airways. You can see that there's bulging of the borders of that radiation zone, that area that was previously, nicely fibrotic. And that's corresponding to some pretty intense avidity, and this is local recurrence. Okay, so that's, we've talked about the expected changes for radiation. Now I'd like to talk a little bit about some considerations for patients who are on immunotherapy. So patients who are on immunotherapy, specifically immune checkpoint inhibitors, which have become a part of the management of cancer pretty much across the board, they present some, unlike the therapeutics that shut down growth pathways or work by DNA damage, these don't shut down proliferation, rather instigate inflammation within the tumor, and that can cause some particular characteristic comorbidities that we have to be on the lookout as radiologists and clinicians managing these patients. So one is radiologic pseudoprogression, and then the others are kind of off-target activity within normal tissues and activation of underlying inflammatory comorbidities such as sarcoid or autoimmune diseases, and that can complicate our interpretation of the disease. So as you may know that pseudoprogression is thought to be caused by infiltration of the tumor by tumor-infiltrating lymphocytes during a successful therapeutic response. This makes the tumor can make the tumor look larger, and can cause the appearance of new lesions that were previously occult and are now infiltrated. If sustained on therapy, the tumor will ultimately shrink. Unfortunately, some patients get pulled off at this point and taken off of what is an effective therapy, and this has been a concern for managed cancer management pretty much across the board. The incidence varies with disease type and with therapeutic. With lung cancer, it's around 2 to 10%. Pseudoprogression melanoma can get up to 15 to some say 20% incidence of pseudoprogression. So, as I mentioned, conventional cytotoxic chemotherapies work by decreasing tumor size, shutting down proliferation, shutting down the growth pathways. The immune checkpoint inhibitors can result in the conventional patterns of response. This is this was actually, I think, the first paper describing pseudoprogression. This is by Who's et al. In 2010, and they described this in melanoma. So if you look at the axis of the chart, it's millimeters of lesions, the tumor lesions, skin lesions. And they looked over time, they characterized 4 different patterns that were associated with a favorable response to immunotherapy. The first 2 you see in conventional responses, conventional chemotherapeutics and targeted agents to growth pathways. So that's either a rapid or a slow, steady decrease in tumor. But they described these 2 additional unconventional patterns that were also associated with favorable response, and that was an initial rise and then fall in the size of the lesions, or a decrease in size of the lesions and the appearance of new lesions. And this was the images that they provided showing this rather dramatically in the skin and melanoma. If you look at the timing, you're looking around, they were describing around days 63 to 105, around several months out, having this kind of peak in ICI-associated pseudoprogression. And here on the pictorials, this is a melanoma lesion at day 0 baseline, week 12, really pretty progressive looking increase in the size of those skin lesions, which then subsequently get more regressed at week 16 and are, nearly gone by week 72. And this is a pretty dramatic example of radiologic ICI-associated pseudoprogression. And we see this also on CT. This is a non-small cell lung cancer on immunotherapy at 2 months of ICI therapy. There is enlargement of the mass, so much so that you've closed off the ipsilateral airway. The right lung is dropped. There's a new effusion. This patient was doing well clinically, surprisingly. And they made the decision to leave this person on therapy. And sure enough, the mass regressed at 4 months, airway opened back up, and they did pretty well, actually. This is another example. This is metastatic lung cancer. So if you look at baseline, also on immunotherapy, checkpoint inhibitor therapy, I believe this was pembrolizumab. And so at baseline, there's, some nodules there, but you can barely see them, right? I mean, it's a few little subcentimeter nodules. At 2 months, now those nodules that were there previously are definitely larger, and they're new ones. This is that second pattern of a radiologic pseudoprogression. Over time, those nodules are, this patient again was doing well clinically. They left them on therapy, and those lesions regressed over a period of months. And I actually don't have it here, but there was a 12-month scan. Lungs are completely clean. So this is radiologic pseudoprogression. In some of the early work that was done, they showed that about 76% of radiologically evident adverse events occur within the first 3 months of therapy. That includes radiologic pseudoprogression as well as ICI-induced pneumonitis and colitis, dermatitis, etc. So most of that is going to happen in the first months of therapy. And that's something that's important, again, for us to know as radiologists where a patient is in their therapy. Not that it can't happen further out, but most do happen in those early months. So let's talk a little bit about what ICI-induced pneumonitis looks like. There are some pretty commonly observed patterns for the appearance of ICI therapy related to pneumonitis. One of the most common is ground glass. That's about taking into consideration, NSIP, which is nonspecific interstitial pneumonia. That's a specific pattern of ground glass, and but taking into consideration all ground glass, it's the more common pattern of manifestation of immune ICI-induced pneumonitis. AIP is acute interstitial pneumonia. Those are much less common, a more fulminant disease that we do see with ICI therapy, but it's less common. Most common is patchy ground glass, organizing pneumonia. And within the ground glass category, nonspecific interstitial pneumonia has a lower lobe peripheral predominant distribution, and we'll talk about that. So looking at this, patchy ground glass, without any other information, and I just pointed out that the patchy ground glass is on a background of a bunch of nodules. Those nodules are metastatic nodules. This patient had widespread mets. It was metastatic lung cancer. And where the stars are, you can see the ground glass. So, seeing this picture, I would be thinking, with a baseline scan only 2 weeks prior, what moves that quickly? Certainly infection can do that. If this was bilateral, I'd be considering also, cardiogenic and non-cardiogenic causes for pulmonary edema. But providing me with the information that they just started immunotherapy 2 weeks prior is extremely helpful, in including that and prioritizing that in the differential. I mentioned before non-specific interstitial pneumonia. This is a less common pattern, but does definitely manifest in this disease, this population. That's characterized by lower lung peripheral predominant. You can have a parabronchial distribution as well, but predominantly peripheral, lower lung predominant ground glass, and you can have interstitial thickening, as you see in this image for the 2 months after the start of ICI therapy. This is also kind of highlighting the very nice subpleural sparing, which is classic for a classic appearance for non-specific interstitial pneumonia. If you don't have it, doesn't mean it's not an NSIP, but when you do see it, it's helpful. This patient, interestingly, after was pulled off of ICI therapy, and 3 months after therapy was discontinued, really, it's not completely gone. You can see like a little bit of subpleural reticulation that is a little bit of scarring that they're going to have to live with, but most of it has has resolved. So this is the NSIP appearance of ICI therapy-induced pneumonitis. And then organizing pneumonia. So, this is a extremely common manifestation of ICI therapy. And, the classic picture for this is central clearing, consolidative opacity with central clearing. You see that to some extent in this case where there's some central areas of ground glass and surrounding consolidation, super common, tends to be lower lung predominant and peripheral. Seeing this without any other information, well, in this distribution, lower lung predominant, I would be considering, aspiration pneumonia. Other possibilities would include COVID, which can have an organizing pneumonia type manifestation where you get a ground glass and consolidation in a peripheral basilar predominant distribution. So again, important to know they just started ICI therapy, and that helps us kind of prioritize that. And this is a much less common, but unfortunately pretty devastating pattern for ICI therapy induced pneumonitis, which is this fulminant acute interstitial pneumonia progressing into ARDS. So this actually was a young woman in her 40s with metastatic leiomyosarcoma, started on immunotherapy, ICI therapy, and started off with these pretty robust ground glass opacities. I don't have all the images through the lung, but the whole lung, there was patchy ground glass, parabronchial and peripheral in distribution, rapidly progressed into consolidative opacities, and then an ARDS like picture with all this residual architectural distortion that she was left with even after steroids managed to squash it some. And she actually died of her complications of this. So it can be quite devastating for patients, as I'm sure you know. And this is another example of organizing pneumonia. Little different appearance to it. This doesn't have the central clearing. This is more of a consolidative nodule. If I saw this image without any other information, with this being the baseline, sure, I'd be considering drug toxicity, but I'd also be considering more strongly, if I don't know anything about the patient, if I don't know that they're on drugs, ICI therapy, I'd be considering infection, particularly a fungal pneumonia, given these kind of nodular densities with surrounding ground glass. Patchy ground glass, certainly fungal pneumonia could do that. Even septic emboli in the appropriate clinical setting could look like that. So again, clinical history is certainly important. Other patterns that the other pattern that's been reported, but I have to say in my own experience, I have never seen it, is hypersensitivity pneumonitis, which is it's been reported as high as 7 to 10%. In this case, you get subtle 1 to 3 millimeter ground glass nodules in an upper lobe predominant central lobe distribution, can be confused with tobacco-related pneumonitis, which is actually where we see it the most, or other causes like environmental exposures causing hypersensitivity pneumonitis. So, and certainly could be, you would also consider an infectious process, a typical infection as well with that pattern. But I have to say, in my experience, it's not been, I've never seen it. But since it is reported, I thought I'd share that with you. We also have, so that's, the drug-induced pneumonitis. Then there are one thing before I even move on, I just want to say that, one of the things we were going to talk about is how to differentiate ICI-induced pneumonitis from radiation. In all of these cases, you can see there's typically bilateral involvement, right? You're going to potentially conforming to, about 10 to 20% of these cases don't conform to a specific pattern, but many do have a peripheral basilar predominant or a parabronchial distribution to suggest a a pattern or this kind of consolidative appearance to suggest organizing pneumonia, but again, bilateral, right? It's not conforming to a radiation zone. So, as was mentioned earlier, knowledge of where the treatment plan was is going to make you a lot smarter about what's going on. If I know, if I only have one of these areas of consolidation, for example, this consolidation on the right, because it doesn't have to be bilateral. It could, you can just get one area of consolidation. Usually it is bilaterally, but I'll struggle unless I know when they've had radiation. So these things are helpful for us to come to the right diagnosis. All right, so just moving on in terms of the other pattern that we see, and this thankfully is not so common in my experience, is this over-exaggerated response to radiation. So this is a patient who's getting concurrent radiation and immunotherapy. It was palliative immunotherapy, radiation for these kind of basilar disease that was causing pleural disease that was causing, and it was locally invasive and causing pain. This patient had like a very overly robust response to the to the radiation pneumonitis that actually ultimately resulted in death. So it was pretty robust, and this patient actually was bronch multiple times. There was no malignancy in this area. It was truly radiation pneumonitis, and wasn't controlled by steroids. The other pattern that we see, that you can see with other therapies, is recall pneumonitis, and that's where you've had radiation in the past, and then you get on immunotherapy, and there is new pneumonitis in the zone of previously irradiated lung. And we see that not infrequently. This is an example of a patient who was irradiated. I don't think in this case I have the exact timing for this patient, but they were irradiated, previously started therapy, and then 2 months late after the start of therapy, there's new consolidation within the treatment zone. This patient was treated for rib met. This is after being pulled off of therapy. Most of it's gone away. There's a little bit of scarring. This typically happens. The mean time for radiation recall pneumonitis is around 3 months, but can be seen, it has been reported up to 2 years out. Okay. And then I just say, we're just, looks like our time is almost nearly up, and I just wanted to just say a few words about where the field is going in terms of additional tools that are under development to make us more accurate in our predictions of response to therapy, diagnosis of response to therapy, and then also prediction of radiation-induced and ICI-induced pneumonitis. I'm sure you've heard radiomics AI, and we have a group at Penn who's working on these some of these tools and development of some of these tools. And these are, this is where you take images, conventionally acquired images on CT, you kind of paint the lesion of interest, and in this case, a lung mass, a non-small cell lung cancer, and then you can extract radiomic features. There's thousands of these embedded digital features within the image that you can extract. You can't see them, but you can process them, extract them, and then do hypothesis testing to ask questions like, can we predict response to therapy? And those predictors are usually, they have a morphological basis, or, for example, in the case of ICI therapy prediction from lung cancer, in lung cancer, the idea is that the degree of baseline tumor infiltration by lymphocytes and mutational burden results in radium features that we're able to extract and predict that patients are more likely to respond to ICI therapy. Similarly, there's work being done looking to see whether we can predict pneumonitis in patients, susceptibility to radiation-induced lung pneumonitis, susceptibility to ICI therapy-induced pneumonitis, and this is work that's ongoing. These are just two, examples in the last year. But if you look on the top right, look on PubMed, and there's it's surging in terms of this is. I searched pneumonitis, radiation pneumonitis, and cancer. And, it's definitely something that people are working on. So hopefully we'll have these tools at our disposal to make us that much better at making these diagnoses properly. All right, so in summary, radiation-induced lung injury changes on CT typically follow a predictable and characteristic evolution over time. The exact timing of that evolution may vary slightly from patient to patient, tumor to tumor, and modality of radiation, but it's a pretty predictable pattern. We suspect tumor recurrence when we see new mass-like consolidation, the appearance of a pleural effusion, disappearance of bronchiectasis where there was previously bronchiectasis within the fibrotic area, and new FTG avidity, particularly when you're outside of that early window of the first 2 to 3 months. Inflammatory-induced changes caused by immunotherapy can result in pseudoprogression, as we saw, inflammatory changes in normal tissues, and exaggerated or recall inflammatory response within irradiated tissues. And I gave you some examples of that in the lung. We didn't talk about this, but you can get reactivation of underlying inflammatory conditions such as autoimmune diseases and sarcoidosis, and that can confound the picture, particularly sarcoid. And you can get a sarcoid-like reaction actually to immunotherapies, similar to some of the chemotherapies actually. But it's important to know for to keep these things in mind when you're trying to interpret the imaging. These are some references, and with that, I'd like to thank you for your attention. And I think at this point we're going to take questions. Am I right?
Yeah, thank you. Thanks a lot, Dr. Moganaki and Dr. Katz, for sharing your expertise today. This was amazing. I mean, I think I personally learned a lot, and these insights were incredibly valuable. I think these were all our real life problems, which we deal with every day, real life questions. So thanks for giving the time and effort. I would also like to thank all our attendees for listening to us patiently as we move through our last part, which will be question and answers. So really, I think the first question, I can start with the first question. Um, so do you? I know we discussed a lot about differentiating immune-related and radiation-related pneumonitis. One question I had is, do you see the rates of pneumonitis in this era, like since we've started using immunotherapy, be actually more than what it used to be before? We have recent data come out from the LAURA trial where they used osimertinib to consolidate EGFR mutant tumors after chemoradiation, and that showed that osimertinib patients had more radiation pneumonitis than the rest of the cohort. So things like targeted therapy, osimertinib, immunotherapy, do they actually increase the rates of radiation pneumonitis that we see?
So I think that might be a better question for Drew, who really has more of a sense of we don't always know what they're on in terms of therapy. I would say that I've seen at least, and I'll defer to him. I'll just say from my perspective, and Drew, please weigh in. I mean, I do think that we see more pneumonitis with the ICI therapy than we certainly did with the conventional chemotherapeutics and targeted agents. But Drew, do you want to weigh in?
Yeah, I think to answer your question, Raj, we have to know what is the denominator. So yes, ICI causes pneumonitis. Yes, radiation causes pneumonitis. The two together, I don't think our empiric evidence is reliable. We have to look at the clinical trial data that shows there's a slight bump, but not a lot. So we're getting away with, concurrent. We have Pembro studies, patients on concurrent Pembro and getting, consolidated radiation metastatic setting. We've got a series of negative phase 3 trials where they literally were giving squirts of immunotherapy during 6 weeks of radiation, and they weren't. The toxicity bump wasn't high enough to stop the study. So I don't think we're seeing that interaction, which I think you're tugging at. But the thing is, is there a stacking incidence? Because TKIs cause pneumonitis, radiation cause pneumonitis, ICIs cause pneumonitis. And that's a really good study question. I don't know what you would do with the information, because if the patient's in front of you and you're running out of options, you gotta go to the chamber and use whatever you have.
Thank you, Dr. Moganaki. Do we have one question in the chat that I'll ask? Anybody else feel free to put any additional questions in the chat or the Q&A. So we have an anonymous attendee who asked, differences in type of lung parenchymal changes and patterns of fibrosis with IMRT versus proton therapy. Incidence of pneumonitis similar or different? And I'll just add on to that, if you could also discuss differences you see in different fractionation schemes. We talked about immunotherapy versus not, but also, maybe the various other systemic therapies when used concurrently or adjuvantly. So just generally incidences and nature of the radiographic findings when you do the different modalities and fractionation schemes.
Yeah, I'd really hoped that single fraction lung SBRT caused less radiation pneumonitis. And I talked to the two smartest people I know who led the phase 2 single fraction lung SBRT trials. They don't even sense even an empiric difference to justify the resources to do a retrospective comparison. So we don't think the number of fractions matters. What I don't think we have a good grasp on is hypofractionation. It's 15 treatments, more or less fibrotic than less fractions. My gut feeling tells me the key thing that matters is volume and dose compactness. And right now, when you do a radiation plan, Sharon, I hope you can keep up with this. So if you come out with a 6-week plan, you just look at a single lung metric. It's like what percentage of the remaining lung got 20% of the 20 gray of the dose? I mean, there needs to be a lot more constraints. And when it comes to SBRT, things can get a little unruly. So there's all sorts of like guardrails, like how much dose is the 2 centimeters? How big is the 50%? And that's great. That's really helped reduce the grade 3, like a prospective study of MD Anderson, nearly 80 patients, they were healthier, but like the grade 3 pneumonitis after SBRT was 1% because they're very compact plans. But what's really interesting, what we don't control is what about the 30% and the 20%? How come there are no metrics? There's no guardrails. The SBRT dose can go here, whatever. And that kind of like randomness of where the beam tracks are going is, I think, the #1 contributor to the challenge in the clinic of already busy medical oncologists, pulmonologists who are even busier, maybe radiologists who are busy to try to find out, like, is this radiation or not? Sharon, fun fact, I was actually trained on radiation pneumonitis by the great Walter Miller Sr.
Yeah.
He taught me about square pneumonia. And I said, what the hell is square pneumonia? Well, back in the days, the beams were squared. You didn't even have a primary collimator to make a rectangle. They were just squares. So if you saw the square track, you're like, okay, that's radiation. But today, these radiation beams, the machine is like treating as it's rotating around this weird discs, like treats for a little bit, treats for a little bit. And so it leaves all these paths. And so, I think that the volume and the shape of these beams, are really the bigger contributor rather than the dose fractionation.
Yeah, I mean, you often see with the SBRT kind of like this arc around the lesion, which I don't have a good example of, but that's usually a good tip off. I mean, you were asking, like, I think the question in the chat was asking, like, yeah, is there anything that can tell, that's obvious in imaging, what type of modality? Usually I can't tell. But I would say, like, if I see that, then I'm pretty confident it's probably an SBRT case. But otherwise,
one thing that's amazing for radiation oncologists to do when you're in a tumor board in MDT, share a video of just a treatment plan. 80 to 90% of them have never seen it. They're like, wait, you can put color on a black and white CT scan? Yeah, and then show the lower doses to show where the beam tracks might be, and they'll never forget seeing that. I've had so many people come back later, hey, dude, that was so amazing that you showed that to. I never saw that through all my training. The person's like an associate or full professor in pulmonology. All those years of training, never saw a radiation therapy plan. So huge knowledge gap, and very simple. Just show a couple plans and boom, now they get it and they know to call you. Give them your cell phone number to make it easier to reach you.
And there's several other, sorry, Dr. Katz, if you had something, I was going to change the topic. Go ahead.
Okay.
Oh, okay.
So I have access to our treatment planning module software at Penn, and on difficult cases, I'll pull it up just to see, because it's so helpful. So yeah, I just want to second that it's really helpful for us to.
Yeah, there are several other questions, but I want to touch on, I think that's a great topic that was brought up throughout the presentation and now by both of you. So you talked about wanting to find a way to help the radiologist correlate more than clinically, with the radiation plan. How are you trying to find a way to allow that communication? Is it just simply providing images of 3 different planes in the treatment summary, or is there a way you can do it in a more kind of perspective or a 3-dimensional fashion?
Well, my recommendation was for the radiologist to provide that to the medical oncologist. The medical oncologist is going to get that report and go, how the heck am I going to correlate with the radiotherapy plan? They're going to have to contact the radiation oncologist. And maybe those conversations will begin this idea of maybe we give them access, although I don't think a medical oncologist necessarily wants to log into a TPS and look at it, but at least they'll call you. And it happens to me all the time. Just yesterday, one of my esteemed colleagues emailed me, hey, can you look at this thing? We want to start antibiotics. We don't know what's going on, et cetera. So the challenge isn't really necessarily for the radiologist. It's for the already busy med onc who's got 6 people in the waiting room, and the person that reports his pneumonitis, like, okay, I got to stop the immunotherapy because Dr. Katz showed people can die. So the visceral fear of a potentially the beginning of what's going to become a hospital admission, ICU ventilation, and death, it's real. So they say, let's stop, let's put some steroids to prevent that from happening. And what we have to do is provide that reassurance, hey, those are just beam tracks. It's okay, but you have to have that communication. And if we're moving in different circles, it's hard to track people down.
So one thing that we do, I will say, it's not uniformly done, which is why I have access to the platform. But and that takes extra time. I think most radiologists are too busy to do that, and I'm too busy to do that with any kind of regularity. It's only when I have like really complicated cases with multiple treatment zones that I want to, just kind of get the lay of the land of what's been done. But what I have seen a number of radoncs do that I find really helpful is they'll take an image of the treatment plan and put it in the chart, in the Epic note. And that is so helpful, because if I pull up their note and it's in there, I'm like, okay, I know what's going on, and I know when
That's great advice.
the date that it was done, and it's just a snapshot. That's all I need. So
all the time we spend on the dose fractionation, all the details that no one understands, or sometimes our notes are more complicated than an ophthalmology note for others, right? All of my completion summaries have a picture for that reason in all 3 planes to the 50%
that's amazing.
Yeah, I would like to stress on that as well. I think in our group we have a couple of physicians, and one of them puts all the images on the notes. So we should have like the dose color wash. That should be a standard template. Like, I mean, that I know that's not a billing requirement, but that should become a technical requirement that you should be putting the 3-dimensional images for everyone to reference. So yeah, no, thanks for those suggestions. In the interest of time, I'll quickly move on to one more question. And as I read this, I realize I was talking about this exact thing yesterday in clinic. Should we be more aggressive in treating radiation pneumonitis early, even if asymptomatic and just radiologic, to prevent or delay progression to eventual fibrosis? Is there any data to suggest impact of progression to fibrosis and possibly help preserve more functional lung by early treatment?
I think there's enough data that convinces us that the policy of steroids for all isn't necessarily helpful. So I don't start steroids. I think the leading thing you can do, I actually give my patients spirometers prophylactic. I say, keep breathing, keep expanding your lungs so it doesn't glue down from a functional perspective. Radiographically, the fibrosis, we have so much to learn about what causes this, how to prevent it, what drugs may interfere, et cetera. But I think keeping the lungs open is the best thing we can do. And I know there's a studies, one of your colleagues there in the Philadelphia area is actually running a trial, and I actually a month ago started handing out spirometers in my large volumes chemo-RT patients I'm worried about.
And what do you do for patients that are refractory to steroids who do have symptomatic changes post radiation?
Well, one of the things is my ladder for managing pneumonitis is I go ahead and start an inhaled steroid early on if they're having any actual symptoms. But if it becomes, even then, I usually get a pulmonologist involved, because God forbid it becomes run away, and then a pulmonologist go, why the hell did you call me 3 months ago, right? So I get I'm not a pulmonologist, so I get a pulmonologist, but then I stay in close contact. I don't just send to a pulmonologist. I work with the pulmonologist as we together figure out, and my number one goal is keep them off oral steroids, not just because of side effects, but also people with lung cancer usually progress and need more treatment. And so, if there's going to be, a possible clinical trial that they want to enroll in, got to be sure that oral steroids, history of oral steroids often will prevent enrollment in the future. But as far as preventing the fibrosis, et cetera, I'm unaware of anything that actually works outside of a clinical trial opportunity. And then you just hope that thing kind of condenses and collapse. And we have that pictorial essay that shows the waxing and waning that can actually happen over 5 years. It's like a pizza dough, someone called it. It just has life in it, like yeast. And so I don't know how to alter the natural history of it.
Great. We have one more question in the chat, and feel free to put another one in if anyone has additional questions. So how do you decide if there's true progression after SBRT in patients who are unfit for diagnosis due to poor lung function? Do you irradiate or wait and repeat the CT? So I assume that means they're unfit for a biopsy.
Also, let me ask Dr. Katz, because we often will lean on radiology to tell us, do you really think this is cancer progression?
Yeah, so I mean, basically, I guess it would really depend on the patient, like what was concerning for recurrence. I mean, I'd have to, we went over some of the basic things that you look for, and I think kind of just, I would want to see the progression of over time, and it's actually those prior images are absolutely key for being able to make the right diagnosis. So just kind of seeing where you started and where things have evolved over time. Actually, whenever I'm looking at these cases, the first thing I do is pull up the baseline, see where this tumor was before it was treated, before it was distorted, and then look over time to see how it's been responding. So I don't think there's a straightforward answer to that. I mean, I think following could be problematic. You would want to know how quickly things are changing, right? I mean, if things are changing very quickly, you might not want to wait to follow it. So I think it's really would be dependent on the patient. Do you agree, Drew?
Yeah, and just to play devil's advocate, we play it all out, and you really in the committee, the conference, usually it's like 3 or 4 people who are voicing, and everyone else is kind of like sitting there going, oh my God, I hope they don't ask me what I think. And so the 3 or 4 people say, yeah, I think it is, you should salvage it. You still got to keep the risk benefit. So you restage, it hasn't metastasized. Can you just keep watching? And then sometimes, is the clock going to run out on the person? If it's not going to run out on the person, you're more likely to take something aggressive. And then you think, okay, what is the risk of this repeat treatment? So if it's in the middle of a lobe, sure, repeat SBRT, plenty of data shows great. If it's right next to an aorta, left ventricle, chest wall, especially chest wall, like, okay, you're going to be on pain medicine possibly for a while after this. So medicine it's an art, and you got to keep a case, but consider each case, and then also you got to really wonder, like, why not do a biopsy? Because the negative biopsy will give you the reassurance to hopefully avoid a high-risk procedure. I generally do not do any repeat treatment without confirmation of progression, in light of what we just discussed in the last hour, uncertainty.
Yeah, I mean, I think the other thing that we typically, that I find helpful is a PET, an FTG PET. I mean, it depends on the timing, but I think, if you're suspicious based on CT, you're seeing a progression over time that looks suspicious, often PET will be helpful. By the time you can see it on CT within that zone of fibrosis, it's big enough that it should be FTG avid, typically. So that's helpful. But yeah, no, I agree. It's like a patient by patient decision-making tree, so.
Awesome. So I think we are almost up with our timing, but I like to thank everyone for listening in, and this was really very informative webinar. Just a couple of more information. If you want to listen into more webinars, we have it listed on our ACR Radiation Oncology website, and feel free to reach out to us if you have more questions. Benefits of ACR membership are again in detail at the website. And with that, I would pass on to Dr. Gogineni and Dr. Amini for any closing remarks, and thanks everyone for listening in.
Thanks, everyone. Have a great evening.
Take care.